Good morning everyone. Today we are going to discuss about the conducting system of the heart. So before going to the conducting system, we are going to see the functional anatomy of the heart including chambers, sounds and pacemaker tissue and conducting system. So myself I am Mrs. Savita Done from Department of Physiology. So specifically I am going to discuss about the conducting system of the heart in all over the properties of cardiac muscle. So learning objective. The learning objective of this lecture is name the parts after finishing this lecture. They are able to name the parts of the conducting system of heart, understand the propagation of electrical impulse in conducting system of the heart, appreciate the importance of AV nodal delay and mechanism of importance of AV nodal delay, the conduction velocity in different cardiac tissues. So these all are the properties of cardiac muscle. The first is excitability, long refractory period, autorhythmicity, conductivity, contractility and all or none law. These are the properties of cardiac muscle. So I'll just enumerate all the properties, but in detail I am going to take the conductive system of the heart. So first of all, in short, we are going to discuss about the structure of the heart and chambers of the heart. So as we all know, the heart is muscular pump. It is weighing about 300 grams. It is the size of fist of our own hand. It having two halls, mainly right and left. The right hall pumps blood to lungs from oxygenation, lungs for oxygenation. The left hall pumps blood to systemic circulation. So chambers of heart. Atria, right atria and left atria. The right atrium receives blood through superior and inferior vena cava, and the atrioventricular orifice here guided by the tricuspid valves. Left atria, it receives blood from pulmonary veins and give to left ventricle through mitral valve. It is separated, the right and left atria are separated by the interatrial septum. Ventricles, left and right ventricle. The left ventricle receives blood from left atrium and give to systemic circulation through the aorta. The right ventricle receives blood from right atrium to give blood to pulmonary circulation through pulmonary artery. The atrioventricular valves. There are right and left atrioventricular valves, they are the right are tricuspid and left are bicuspid, or it is also known as mitral valve. The semilunar valves, they open away from the ventricles and close towards the ventricles. The closes when ventricles relax and prevent the backflow of blood into the ventricles. Now the structure of wall of the heart. There are mainly three layers of the heart: pericardium, myocardium and endocardium. The pericardium is made up of by fibrous and serous layer which is filled with the pericardial fluid. The myocardium, which is having cardiac muscle, pacemaker tissue and conducting system. The endocardium continues with the endocardium of great vessel and it is opening into the heart. So this is the structure of heart. Now causes of heart sounds. There are mainly two heart sound, first and second heart sound. Third and fourth heart sounds are also there, but they are not normal. They are not heard in normal conditions. The first heart sound, the cause of first heart sound is closure of AV valve, that is atrioventricular valve. The second heart sound, the cause is closure of semilunar valves. The third and fourth heart sounds are also there. Third heart sound is due to vibrations of ventricular wall and AV valves caused by the rushing of blood during first rapid filling phase. The fourth heart sound is due to atrial systole in last rapid filling phase. Here, the first and second heart sounds are heard by stethoscope, but the third and fourth heart sounds are only heard by the phonocardiogram. So this is all about the structure of the heart and function of the heart. As we know, it pumps the blood, it provides the nutrition. All these are the functions of the heart. And areas of the heart, that is 4 areas, 2 atria and 2 ventricles, and functions of those areas. And about the heart sounds, mainly 2 heart sounds which are heard by the stethoscope. Here the first heart sound is better heard in the mitral area, and this heart sound is coincides with the carotid pulsations. Whenever we whenever we auscultating the first heart sound, that time whenever we keep 2 fingers on the carotid pulsations, they both are coincides. So the first heart sound is coincides with the carotid pulsations. Now the second heart sound, it is better heard in pulmonary and aortic area. So all of we know the cause of first and heart sound. Cause of first heart sound is closure of AV valves. Second heart sound is because of closure of semilunar valve. Now we are going to see the property. I already mentioned or enumerate all the properties of the cardiac muscle, that is excitability, long refractory period, autorhythmicity, conductivity, contractility, and all or none law. So today I am going to highlight the conductivity of the heart, that is conducting system of the heart. Here we see the rhythmic excitation of the heart. The generation of impulses are there from pacemaker tissue, the conduction of impulse from conducting tissue. Here, because of this, atrial contraction and ventricular contraction is there. Here all portion of ventricular muscle is contract simultaneously. Now the action potential in cardiac muscle. Here in cardiac muscle, the plateau potential is there. Normally in action potential we see the spike potential, or it is also known as spike potential, but here in cardiac muscle there is plateau potential. There are mainly total 5 phases from 0 to 4, but numbers are 4. In phase 0 there is opening of fast sodium channels. In phase first, the closure of fast sodium channels, which opens the slow in phase 2, the opening of slow calcium and sodium channels, there is decrease in the permeability of the potassium channels. So here the plateau is there. Phase 3, closure of slow calcium and sodium channels. It increases the permeability of the potassium channels. In phase 4, prolonged opening of potassium channels are there. It causes the hyperpolarization. Now the pacemaker. The part of the heart from which rhythmic impulses from heartbeat are produced is called as pacemaker. In mammalian heart, the SA node, AV node, atria and ventricles are there. But SA node is the pacemaker because it generates the more impulse as compared to the other structures of the heart. As we know, in amphibian heart, the pacemaker is sinus venosus. In amphibian heart, only 2 atria and 1 ventricle is there, and the pacemaker is sinus venosus. There, the mixing of blood is occurs. Here in mammalian heart, there is no any mixing of blood is there. Now, the rate of production of rhythmic impulses. The SA node produces 70 to 80 beats per minute. The atrioventricular node, it produces the 40 to 60 beat per minute. The atrial muscles, they generate 40 to 60 beats per minute, and ventricular muscles 20 to 40 per minute. Now the pacemaker potential. Pacemaker potential is seen in pacemaker cells like SA node, AV node. The self-excitation is there here. The resting membrane potential is minus 60 to minus 55 millivolt. It is because of due to leaky sodium and calcium ions. It trying to neutralize intercellular negativity, and it is close to the firing level. Action potential in specialized conducting cells, that is pacemaker potential. As I discussed earlier, the resting membrane potential is about minus 55 to minus 60 millivolt. There are leaking of sodium and calcium ions, and it reaches the threshold of minus 40 millivolt, and the slow sodium and calcium channels are activated and the action potential is generated. The slow sodium and calcium channels inactivates the potassium channels are open. So the resting membrane potential is reached. Because of potassium channels closed, here again the cycle is repeated. Now the autorhythmicity, that is self-excitation. Whenever there is resting membrane potential in cardiac muscle minus 55 milliliter, high sodium in ECF and leaky sodium channels are there. Because of sodium influx, there is rising of membrane potential slowly to positive side. It reaches threshold level, that is minus 40 millivolt. There is opening of fast sodium and calcium channels. So this is repetition of the previous slide. Because of this, the rapid depolarization is there. The opening of potassium channels causes the rapid repolarization, and the cycle is repeated. Now the sinoatrial node or SA node. Sinoatrial node or SA node. The sinoatrial node is specialized cardiac muscle. It is located, the site of SA node is, it is located in superior posterolateral wall of the right atrium, below lateral to opening of superior vena cava. Features: the fibers have no contractile filaments here. It connected directly with atrial muscle fibers, and the action potential spreads immediately in atrial muscles, and it develops the pacemaker potential. So this diagram shows how the impulse generates from SA node to the AV node. Here from SA node the impulse generates to the AV node through the internodal pathways. Mainly there are three types of internodal pathways are there, through which the impulse from SA node to AV node is transmits. AV node to bundle of his, there are left and right bundle of his is there, and bundle branches are there. Bundle branches are bifurcated to form the Purkinje fibers or ventricular syncytium. So all of you see this diagram carefully. From SA node to Purkinje fibers, how the impulse is transmits. So this is the diagrammatic representation of the conducting system of the heart from SA node to Purkinje fibers, or how the impulse is travels. There are three internodal pathways are there. Anterior internodal pathway of Bachmann, the SA node Bachman, and middle Wenke-Becke, and posterior internodal pathway of Thorel. These three are the internodal fibers which connects the SA node to the AV node. From AV node, there is bundle of His arises, and it is bifurcated into left and right bundle of His, and it runs through the interseptal or interventricular region, and they forms the Purkinje fibers. Now the AV bundles. Here normally the one-way conduction is there through the bundles. Only the conducting pathway between atria and ventricles is AV node and AV bundle. It divides into the left and right bundles, where the transmission time between atrioventricular bundles and last of ventricular fibers is 0.06 seconds. So it in ECG, on ECG it suggests or it shows the QRS time. Now the cause of AV nodal delay. What is the significance of AV nodal delay here? The AV nodal delay is about 0.1 second. The significance of this is it allows time for the atria to empty their blood into the ventricles before ventricular contraction is begins. So this is the significance or advantage of this AV nodal delay, and it is about 0.1 second. The significance is, once again I'll repeat the significance of AV nodal delay. So it allows the time for the atria to empty their blood into the ventricles before the ventricular contraction is begins. So the cause of slow conduction here is it mainly by diminished numbers of gas junctions between the successive cells in the conducting pathways, so that there is great resistance to conduction of excitatory ions from one conducting fiber to the next. So this is the cause of slow conduction. What is the slow conduction? The cause of slow conduction is mainly by diminished numbers of gap junctions between the successive cells in the conducting pathways, so that there is great resistance to conduction of excitatory ions from the conducting fibers to the next. Rapid transmission in the ventricular Purkinje system. Rapid transmission in the ventricular Purkinje system. The transmit action potential at a velocity of 1.5 to 4 meter per second. They transmit, the Purkinje fibers transmit action potential at the velocity of 1.5 to 4 meter per second. So cause very high level of permeability of the gap junctions at the intercalated discs in the Purkinje fibers. Because of this, there is easy transmission of ions, and they enhancing the velocity of transmission. This is the cause. So the significance is the action potential spreads all over ventricular muscle fastly, so whole of ventricular muscle will contract at same time to generate more force of contraction. What is the significance of this rapid transmission in the ventricular Purkinje system? That is, action potential spreads all over ventricular muscle fastly, so whole of ventricular muscle will contract at same time to generate more force of contraction. This is the significance. Now, the transmission of the cardiac impulse in the ventricular muscles. It is transmitted through the ventricular muscle mass by the ventricular muscle fibers themselves. So here the transmission of cardiac impulse in the ventricular muscle, from where to where? It is transmitted through the ventricular muscle mass by the ventricular muscle fibers themselves. The velocity of transmission is now only 0.3 to 0.5 meter per second. Now the cardiac activation time. First, there is atrial activation from SA node to AV node. So this cardiac activation time shows in seconds the atrial activation from SA node to AV node. The septal activation from left to right. Here the septal activation is from left to right. The activation of anteroseptal region, the ventricular myocardium. It is 0.16 seconds. The activation of major portion of ventricular myocardium from endocardial surfaces. So this is 0.21. The late activation of posterobasal portion of the left ventricle, the pulmonary conus and uppermost portions of the septum. Here, this shows the spread of cardiac impulse from SA to AV node, from septal activation of anteroseptal region, activation of major portion of the ventricular myocardium from endocardium surfaces, left activation of posterobasal portion, that is the left ventricle, the pulmonary conus and the most portion of the septum. Thus, there is spread of cardiac impulse. So this diagram is also shows that is spread of cardiac impulse and the main arrival times. The main arrival time from SA node to AV node is 0 second. AV node is atria to ventricle is 0.03 second. AV bundle is 0.12 second and ventricular septum is 0.16 second. So this is the arrival time of cardiac impulse, time of arrival time. Have you got? Now, why the sinus node is cardiac pacemaker? Why the sinus node is cardiac pacemaker? The normal rate of discharge in sinus node is 70 to 80 beats per minute. And from AV node it is 40 to 60 beats per minute. The Purkinje fibers generates the 15 to 40 beats per minute. Here the sinus node is pacemaker because of its faster discharge rate. The discharge rate is more from the SA node, that's why it is called as pacemaker. Pacemaker of the heart, the pacemaker of human heart, because of faster discharge of the rate or faster impulse generation by the sinus node is more as compared to the other structures of the heart. As in human, the pacemaker is SA node, but in mammalian, in amphibians, the pacemaker is sinus venosus. Now the abnormal pacemakers. The AV node and the other parts of the conducting system can generate impulses in abnormal conditions and function as cardiac pacemakers. Here, the diseased atrial and ventricular muscle fibers can discharge impulses repeatedly due to the reduction in their membrane potential. If there is any reduction in the membrane potential, then there is a reduction in impulse generation. Now the applied physiology of this conducting system. There is abnormality of the in rhythm, that is known as arrhythmias. There are sinus arrhythmias, paroxysmal tachycardia, the atrial flutter and fibrillation. Because of this, there is abnormality in the rhythm of the heartbeat is there. The ventricular fibrillation is also caused the abnormal rhythm of the heart. The ectopic beats are also there in the abnormal rhythm. Now the abnormality of the conduction. If there is SA nodal block, then the conduction generation or transmission of the conduction is cut off from the SA to AV node. that is abnormality in the conduction. SA nodal block causes the abnormal conduction. AV nodal block. There are mainly three types of AV nodal blocks. The first degree block, second degree block and third degree block, depending upon the how much the defect is occurs in the conducting system of the heart. The ionic imbalance. Ionic imbalance also causes the abnormal conduction of the impulse generation of impulse. So here hyperkalemia, increase in the potassium, that it decreases the conductivity and causes the heart block, and it also decreases the excitability of the cardiac tissue. Hypercalcemia, if there is increase in the calcium level, it increases the contractility of the heart. So these are the ionic imbalances. So as I said, hyperkalemia means increased potassium level in the blood. It causes the decreased conductivity and it causes the heart block, and excitability, it decreases the excitability of the cardiac tissue. Hypercalcemia, if excess calcium is poor on the frog's heart, that time there is increase in the contraction of the heart or calcium rigor is occurs. So more calcium level in the blood causes the increased contractility of the heart. Heart block. The damage to the conducting system of the heart hampers impulse transmission. So this result in heart block. Depending on the site of the damage, it is categorized as follows: the sinoatrial block and atrioventricular block. Depending upon the extent of damage, it is categorized into the first, second and third degree heart block. In first degree heart block, the PR interval is prolonged beyond the 0.2 seconds. So, the PR interval is prolonged in first degree heart block. In second degree heart block, all the atrial impulses do not reach the ventricle. The ventricular beat may follow second or third atrial beat. It is termed as 2:1 or 3:1 heart block. The P wave is not regularly followed by the QRS complex in second degree heart block. The complete heart block or third degree heart block. The transmission of impulse from, what happens here is, the transmission of impulse from atria to ventricle is completely interrupted. Here the ventricular beat at lower rate termed as idioventricular rhythm. So what happens here in third degree heart block is, the transmission of impulse from atria to ventricle is completely interrupted. So it causes, or the ventricular beat at lower rate termed as idioventricular rhythm. Now, artificial pacemaker. Artificial pacemakers. Here, artificial pacemakers are external electronic devices implanted when the patient has severe bradycardia due to defective functioning of the natural pacemaker or the conducting system of the heart. Here, whenever there is any diseased condition or any defect in the natural conducting system of the heart, that time the artificial pacemakers are applied externally to the patients. So this is all about the conducting system of the heart. So in this point, the most important thing is, you have to know from where to where the cardiac impulses generates and how it spreads all over the heart. Once again, I'll show you the diagram of the conducting system, how the impulses generates from SA node to AV node. So this diagram shows how the impulses generates from sinoatrial node to AV node. Here 3 internodal pathways are there. the posterior internodal pathway of Thorel, the anterior internodal pathway of Bachmann, and the middle internodal pathway of Wenckebach. So from SA node to AV node, the impulse is transmitted. From AV node, it bifurcates into the left and right bundle of his bundle branch and Purkinje fibers.